provide an update as to some of our UW-Medicine response to the COVID-19 pandemic. First, I want to just acknowledge the significant challenge that this pandemic is causing globally, as well as here locally within our community, not only in Seattle, the Puget Sound, Washington area, but also as we see increasing number of cases identified across our country. I also want to just really sincerely acknowledge and let those individuals who have been directly affected by COVID-19, our patients, their families, let them know how much our hearts go out to them. We realize how challenging this has been as we are seeing this escalation of cases within our community. I also want to thank all of our partners here within the Northwest. While this is a global pandemic and you wouldn't want this to happen anywhere, we are extremely lucky to be here in the Northwest because we have wonderful partnerships with our public health colleagues, with our Department of Health colleagues, with the Northwest Healthcare Response Network, and this really is a time where all of our healthcare systems are coming together to best serve our community as we really engage and do everything we can with this emerging pandemic. I also want to thank all of our employees at UW-Medicine, our healthcare workers who have stepped up, as have all healthcare workers across our region in response to this COVID-19 outbreak. I'd like to share a few of the specific things that we have been doing from a UW-Medicine standpoint. Since early January, when we first heard about this cluster of patients in Wuhan, China, who were diagnosed with a pneumonia of unclear etiology, we began tracking what was happening there. On January 7th, it became clear that this was due to a novel coronavirus. Our infection prevention teams from across our system were actively following and working and building upon our preparations. And I would say that our preparations really date back not only to the 2009 H1N1 pandemic, but also our experience with the West African Ebola outbreak in 2014. We then saw the first case here in Washington State, unfortunately on January 20th. And we continued to work with our public health colleagues and really in partnership with them, really trying to identify any potential new cases within our community. In fact, Harborview stood up a home assessment team in partnership with public health to really provide in-home assessment and testing capabilities at that time, particularly for return travelers from areas that were affected by this outbreak. Towards the end of the last week in February, on February 28th, all of us realized that we had community transmission here with the announcement of the high school student in Snohomish who was diagnosed with COVID-19. We subsequently learned of an unfortunate death at Evergreen Hospital. One of the important characteristics to remember at that point is that we had a modification in our thought process during that week as we transitioned from thinking of those return travelers who came from high-risk areas and thinking about could this potentially be COVID-19 to then thinking about within our community, do we have cases of undiagnosed pneumonia? And I give a lot of credit to the physicians and team at Evergreen for making that diagnosis. That was a critical time within our community because it signaled that we do have ongoing transmission within our community, and that travel history became much less relevant. On February 29th, UW-Medicine implemented our incident command structure across our system, as well as within each of our hospitals. We did this to align and better coordinate our activities across our entire system, and this is very similar to what other healthcare systems have done. With that increased coordination and alignment, we have spent a lot of effort on communication. We are in a rapidly evolving period of time right now, almost by the hour, and so that clear communication, not only within all of our employees and staff, but also within the community and our partners. We have worked together with other healthcare systems to align our activities and how we best keep our healthcare workers safe, which is our #1 priority, as well as best manage patients who may present with possible COVID-19 symptoms. We also are very fortunate to be here at the University of Washington, where we have wonderful researchers. From the time those first patients were diagnosed in Wuhan, China, and it was determined that there was a novel coronavirus, our clinical virology lab began working on a test that then was available for our patients and our community as of March 2nd. That testing, which we can discuss more with the question piece, has now been up to 2,000 potential tests a day, and we anticipate being able to handle upwards of 4,000 tests by next week. Just to give you an example of how this is ramped up, just yesterday we did 1,300 tests within our community. Now, the majority of those tests currently are negative, less than 10% are positive, but we anticipate that may change as we continue to see this pandemic evolve. The other things that we have done, and again, sharing all of this information with our community partners, is for the protection of our employees, we have set up a drive-through employee testing clinic. We did that so that any of our employees who have any symptoms are able to be tested and determine whether or not they may have COVID-19, as well as any other potential viral infection. We also have been really looking at what do we have to do, and again, all healthcare systems are doing that in terms of how we practice medicine. We are no longer in a business as usual period. So just as an example, ramping up telehealth. So one of the things that we have done is to ensure that all of our primary care providers are able to deliver telehealth services. The more that we can care for our patients and maintain that continuity of care in the community and not have them need to come into the clinics or hospitals, the better. This is also important, going back to the testing. It's important to understand that the decision to test is really a clinical judgment by the patient's provider based on their clinical symptoms and risk factors. While the University of Washington, our virology lab, can perform the test, the sample actually has to be collected by those outside clinicians and then sent to our lab for processing. And so I just wanted to clarify that because sometimes there's been a misunderstanding in terms of what we're able to do. What we don't want people to do is to just show up to be tested because they are concerned without first going through their clinician to see, do they have symptoms that are compatible and should they actually be evaluated? If we don't do that, we will overwhelm our clinics and overwhelm our emergency departments. Now, many of you saw some of the social distancing metrics that the governor and the local jurisdictions have implemented. It's critical that we do that at this stage of the outbreak to what we refer to as flattening the curve, meaning for our health systems to continue to function, to be able to provide the care not only for those patients with COVID-19, but for those patients who need other medical care. We have to decrease the volume of patients coming into our facilities and spread that over time. And so that's why those social distancing measures that the governor and others have implemented are so critical. And this is why we are really emphasizing the biggest thing that people, particularly with mild symptoms, can do is to stay at home. Don't go to work. And we're telling all of our employees the same thing. If you have symptoms, please stay at home. Check with your provider if you have questions, but we really need to keep our healthcare workers and our workforce healthy and safe while we continue to fight this pandemic. Now, another development that I want to share with you is that we have learned that we have 2 patients in our geropsychiatric unit on the UW Medical Center Northwest campus that have been diagnosed with COVID-19. And I'm going to turn it over to my colleague, Dr. Santiago Neme, to discuss the details of those 2 individuals and, most importantly, our response as we continue to ensure the safety for our patients as well as our healthcare workers. Santiago.
Thank you, Tim. So my name is Santiago Neme. Good afternoon. Like Tim, I'm an infectious disease doctor, and I'm the medical director for UWMC Northwest. Earlier today, we found out that 2 of our patients in the geropsych unit turned positive for COVID-19. These patients were quickly tested and put on precautions while their test was pending. Quite immediately, we convened a group to talk about the situation. Briefly, the geropsych unit is a unit that has 27 beds. All but 2 or 3 rooms are individual rooms. And again, 2 of 22 patients tested positive. Immediately after knowing that, that 2 of the patients tested positive, and also in understanding the environment of a geropsych unit where there's socialization, there's group activities, we immediately decided to start precautions for all 22 patients. Precautions meaning that we instituted our special droplet contact protocol for each room with specific techniques around donning and doffing protective personal equipment, also known as PPE. We also, as part of the strategy in trying to investigate this, the development of these 2 cases, the natural question is, could there be more patients affected by this? So by 1 p.m., we had tested all 22 patients, and their tests are now pending at our virology lab. We also discussed the case, these 2 cases with the staff, and immediately after we started conversations with the family members of those patients. At this moment, the 2 patients who were positive were transitioned to the medical side to make sure that they're safe and away from the other patients. Those 2 patients that remain stable, in stable condition. And family members have been, again, communicated, and with full transparency, we discussed what the plan was, both for those 2 patients, but also for the rest of the patients. We typically do not test everyone, but in this situation, we needed to get more information and really jump on it quite rapidly to make sure that we understand. And luckily, fortunately, with the University of Washington testing, we could actually get that information. We're going to be able to get that information pretty quickly. The patients that we did test seemed pretty stable also. And there were no concerning signs or symptoms at the time. And the plan, again, is to reinforce hand hygiene practices, reinforce the use of protective personal equipment, also inform staff that this is a pandemic, and everyone's affected. As some of us have said in the past, viruses do not discriminate. They affect everyone. There are people in Italy struggling. There are people in France. There are people in New York, everywhere, really. So what we can do, I think, as a community, especially healthcare community, is to not panic and really get informed and know what our tools are to get better. So therefore, we provide frequent updates to the medical center, included at 3 p.m. today. We had a town hall because we want to really encourage distancing. This was done via an application where folks could call in remotely, and we had greater than 100 participants calling in, and some folks were live in person. But again, to gain transparency and to let staff know what we're doing. But in this, I feel, as Tim said, these situations are challenging, and no one's having fun, and this is affecting our lifestyle, the way our kids are not going to school, childcare, all these things that are happening, the ability to go on vacation and things like that. But I would say in terms of of preparedness. I feel very confident in our efforts through UW Medicine that the system has been organized for several weeks, and leaders leading this effort have been organized for years, including our colleagues at Harborview, with really special skills to handle these situations. So that's the summary, and we're happy to take questions.
Those two patients, have they been in that unit a while, or did they come in with the infection with them, or do you know?
Yeah, so some of the challenge with folks, so the unit has, I would say, approximately 2/3 of the unit is an involuntary admission. So there are patients who struggle manifesting symptoms, but there were no overt signs of respiratory infections in either patient. It is unclear whether they came with the infection. I suspect that they might have. Again, we at the Northwest campus, we serve a population that tends to be elderly, and not infrequently we have folks who live at skilled nursing facilities or long-term facilities. So we're doing part of that investigation to track that and also inform where they came from. But I would have to say that it's challenging in terms of the symptoms, and especially in the elderly, what we're seeing is that some folks are subclinical. And when you add the mental health issues and the inability to freely express symptoms really clearly, then it adds a complexity, an additional complexity.
I just want to build on something that Dr. Neme said. When you look worldwide around the severity of illness, and we're still learning about the range of disease, typically 80% of individuals will have mild disease, and they won't require any hospitalization or higher level of care. What we also have seen, though, that the individuals who are at greatest risk for more severe disease tend to be those individuals older, particularly over 60, but it continues to go up with older age, as well as those individuals who have underlying medical conditions. And unfortunately, what we've seen with our local outbreak, really in a very tragic way, is what we've seen within our long-term care facilities. Right? We have seen, unfortunately, those individuals who are older in age be really directly impacted by this virus. And I think this is one of the challenges as we look at the symptoms, that we know with most infections that individuals, as they get older in age and their immune system wanes, that they don't often present with the classic symptoms. And so while we often think of fever, cough, as some of the primary symptoms that people present, and in fact, if you look at some of the early cases, almost everyone had fever in those early cases. But as we learn more about the different patient populations affected by this infection, we are going to see that in some, and I think that's what we're learning here in our local experience, is that sometimes those individuals who are older in age don't manifest all those symptoms, which creates even more challenge to be able to identify those. But I think it's an important part that we as a medical community are all learning as we go through this together.
Are you guys able to provide any more information on the patients who tested positive, age, gender?
Not at this time. They're both in stable condition, but not at this time.
And what unit did you say was again? I'm sorry.
It's a geropsychiatric unit, which is the only geropsychiatric unit that we have within our community, but it is then does care for individuals who are older and potentially at increased risk should they get infected with this virus.
So it's older people with mental health issues?
Yeah, with mental health issues.
And some are in there involuntarily?
2/3 are involuntary, yeah.
Are you going to be are there plans to test the healthcare workers that have been treating these patients?
Yeah, so for healthcare workers, we have a screening process, and you guys, as some of you have actually visited the clinic, where our policy or recommendation is that everyone with symptoms should get tested, and they call and they get tested quite rapidly. Now, for exposed professionals, we have a risk stratification as to what type of exposure. A close contact, like being within 6 feet of a patient and also for prolonged periods of time, increases the risk of infection, right? Because the length of exposure matters in terms of infection transmission. So we we risk stratify providers, but the key message here is that the message to healthcare workers is that if they need to monitor symptoms twice a day. If they're asymptomatic, they may return to work. But the minute they get a symptom, they go off work and they get tested. That's our recommendation, which is in line with the public health recommendations.
I also just want to build upon, again, what Dr. Neme was saying. Normally, we recommend not testing people who don't have symptoms. The reason we're doing this, particularly within this unit, is because of the identification of these two cases. And this is similar to what we would do if we happen to see an increase in influenza cases in a particular unit or norovirus in a particular unit, that we do additional monitoring and surveillance to look at those individuals who may have been exposed. But again, I want to emphasize for the community that we really discourage routine testing of people who do not have symptoms. It's really not indicated.
Where did these two patients come from before they entered this particular ward? Were they in nursing facilities or in a family home or homeless, or do you know?
One of the individuals came from another long-term care facility, and we're working with public health in terms of that evaluation.
Have there been other cases at that facility?
Yeah, I think it's too early to tell. We're just starting that process with public health.
Going back to testing for a bit, I do feel like as this virus continues to impact our city, there are more people raising questions about what testing looks like and the logistics of it all.
Mm-hmm.
I know that you guys are not recommending that you go get tested if you don't have symptoms, but if a provider does decide to
Mm-hmm.
test a patient, what's that look like for them? How much are they looking at paying? What resources they have to contact?
Mm-hmm. So the test itself, again, this is a respiratory virus. It's the same nasopharyngeal swab that we use to test for influenza or other respiratory viruses. So from a patient standpoint, when they're in their physician's office, as an example, the test is a swab that goes through into the back of the nasopharynx, and then that swab is sent to the lab, and it could be our lab or it could be the state lab. And then the lab does what's called a PCR test, where they amplify the genetic material to see if the virus is present. And within our lab, the turnaround time is right around about 10 hours now. So if we get those samples in the morning, we typically have the results by the end of the day. So the testing from a patient standpoint, it's the same sort of collection of a sample as you would do with influenza or other respiratory viruses. Now, you asked about the cost. The cost from the lab standpoint is, I believe, around $250, which is the same price if you look at other labs around the country who are able to perform this test. Now, our insurance commissioner in Washington State has been working with payers to be able to waive deductibles, waive co-fees. And what I really want to emphasize is that the ability to pay will never be a barrier for us in terms of being able to appropriately care for the patient. And if they need testing, we will get that testing done. And there is a lot of work to look about the overall funding of that, efforts just like the insurance commissioner did. But again, we don't want that cost to be a barrier. This is a public health crisis, and we and all of our partners within the community are responding and testing whenever it's indicated.
And we seem to be hearing so many different opinions about whether or not testing is actually readily available. Thoughts?
Mm-hmm. So I want to put this in context too. So when you have an outbreak like we're having within our community, testing is an important component, but it's not the only component. For an individual patient with mild disease, it's not necessarily going to help that individual patient other than they should be staying home. But they should stay home if they have influenza or any other respiratory illness as well. It does help from an overall surveillance of understanding, well, what is happening within our community in terms of transmission and how many cases. And so there's a surveillance aspect, particularly from a public health standpoint, that is of value. From a medical side, those patients who are admitted to the hospital with respiratory symptoms, we definitely want to test, because we need to know how best to manage them and what sorts of precautions to use for them while they're receiving care, whether they have COVID-19 or if they end up having something else if they require hospitalization. Public Health has also put out a prioritization list, and so while they say that testing can be available to anyone for whom their clinician feels within their medical judgment, it's indicated they're also prioritizing groups. So they're prioritizing individuals who are over age 60, prioritizing individuals who have underlying medical conditions. And so all of that goes into the judgment of the clinician. So the availability is there. Our lab right now, as I mentioned, we can do roughly 2,000 tests a day. We haven't hit that capacity yet. We are actively working with our lab medicine colleagues to try to increase the number of tests as well. And in fact, we're working with public health because sometimes we're helping them with their backlog of tests also. And so the other piece I would just mention, you're going to see more and more commercial labs that will be coming online across the country as well. And so there's a lot of effort to ensure that testing is available when it's indicated. But I also want to emphasize that it's not the only way that we're going to be able to control. It's an important piece, but some of these measures, such as the aggressive social distancing and just preventing someone who is sick or ill with symptoms from COVID-19 from being in contact with someone who is not, that's the biggest thing that we can do within our community. So I just, again, really want to support some of the social distancing policies and the approach that public health and the governor have been recommending over the last few days.
Just a little bit on the context of how much of a shock this is to discover these two patients now. Are these the first two patients in the UW medicine system? No, they're not.
No, we have had, if you look across our hospitals, we have had, for instance, today we started the day probably roughly around 20 patients across our 4 hospitals, and then we had a number of other individuals who had tests pending. So we and all hospitals have patients who have COVID-19 infection. What was unique in this situation is that we identified these 2 individuals who were within the unit and had not come in specifically for COVID-19 symptoms.
And only one of them had been at a long-term care facility prior to coming.
That's my understanding.
Yeah.
The 2 patients sharing a room per se, or is it 2
Yep.
patients that had different rooms sharing with other people?
You know, one of the challenges, they all have single rooms, but you know, when you care for a population with mental health conditions, and particularly in any psychiatric unit, a lot of the therapy is a combination of group therapy. There's a much more intermingling in more of an open unit as opposed to what one would think of as a typical medical or surgical unit. So, and that's so that they receive the care that they need for their mental health condition.
What's that look like now? Do you quarantine everybody into their own little space?
So yeah, so the 2 patients who were diagnosed earlier today, they were moved to a different area. Then what we have is, out of the patients that we tested, there were a couple who had some symptoms now, and so then everybody is in isolation, so we basically we have the assumption that everybody is infected, right, until we have test results. So everybody is in independent rooms, especially those folks who have the 2 or 3 who have some respiratory symptoms today. Those are independent rooms. So that's what you need to do. You need to just assume that the infection is larger. You need to be very conservative, and as you get more information, which is the testing, and we should have that information pretty quickly. But yeah, it's infection control practices, is isolation, and it's communication with the staff, communication with the families, and making sure that folks understand the environment. And then restricting those activities too, because now the socialization unfortunately cannot occur until we have more information. But the idea is that if any of the other patients turn positive, we're going to have to kind of group folks in that regard, and then plan accordingly.
We've heard from some facilities that, like, about a shortage of masks and robes. And have you guys had an issue with any of your employees having to reuse masks or anything?
Yeah, so I can make a few comments. Again, our number one goal is to keep our patients and our healthcare workers safe, and we absolutely must have appropriate personal protective equipment so that our healthcare workers can safely care for patients, whether it be with COVID-19 or other medical conditions. I think all facilities are actively monitoring and tracking their PPE supply. This is a challenge because worldwide there is a shortage of supply and production, and I think you've seen there have been, just even in the last week, a few companies just starting to come online within our country to try to help with some of that supply shortage. What we are doing then within our facility is also what are those steps that we can do to conserve our PPE? So again, not business as usual. So simple things are when we have, again, we're a teaching facility, so that rather than having the whole team that may include senior physicians and residents and medical students, only limiting that to the primary person who needs to actually go into the room to use that PPE, while then discussing the patient with the rest of the team outside of that room. Being thoughtful about how many times do we actually have to go into that room, using other technology, if we can use video technology to avoid having to go into the room, to still provide the same level of care, but not have to use as much of that personal protective equipment. The CDC has also put out policies around reuse, and so those are things that we can look at. And in some situations where, for instance, if we're caring for a patient with suspected tuberculosis, as an example, where we may also use an N95 respirator, in that situation, we can use that respirator more than once if we're caring for a tuberculosis patient, in part because it's not spread by direct contact. So the other place that we're really looking is in the operating room. So who are the individuals who are participating in the surgery? Again, all the essential care members of the team must be there, but if we have other individuals, we may start to limit those more to really preserve the amount of PPE that we have. We also have made a request to the National Stockpile for additional supplies, as have other healthcare systems, and again, that's being coordinated through Public Health and the Department of Health as well. So I think all of us are working together to think about both how do we preserve the PPE that we have on hand, what are the supply chains like, reaching out with all of our vendors, but also then really thinking about, for us as a system, how do we do this in a centralized process to be able to shift supply where we need within our system to be able to provide and meet the care needs in a given location.
One related area I would like to add is, since hand hygiene is so paramount, I had to remind folks, patients who call me about concerns about not finding alcohol gel or, at the stores. There's always soap and water, so folks are using more soap and water, which is great, and we know that it's effective and it's safe. So,
that's a great point. We also really need to emphasize to the public, if you are not in healthcare, please do not hoard these supplies. We have to essentially keep our PPE really under lock and guard, and also really be careful in terms of how much we distribute to a given unit to be able to, again, meet those care needs, but not have it as readily accessible. And again, I think totally appreciate the concerns within the public, but we really need to preserve that PPE for the healthcare workers so that they can safely care for our patients. This is vital to our community.
I just wanted to ask if that gear was used by the staff in this particular psychiatric department, if they were wearing masks and gloves and doing all those, or if that was not part of the standard protocol.
That protocol would kick in if you have any suspicion of a respiratory infection. The staff at that time didn't have that suspicion, so therefore we don't put the entire hospital under this special PPE protocol. It's not doable and it's not indicated. So in this case, there was clearly no suspicion of a respiratory infection, so therefore they weren't the standard precautions, which again are hand hygiene, use of gloves, etc. So, but now everyone is pending testing.
I think it goes back to what we discussed before in terms of, unfortunately, sometimes in some of our older patients not manifesting the classic symptoms that would trigger that sort of a response. And so that is something that all of us in the healthcare profession we need to think about, but they did not have those classic symptoms that would have led to those precautions.
And this might be a silly question, but is that because the virus seems to be evolving, or we're just learning more about it?
I don't think this is an issue with the virus. I think it's an issue about the particular host. It's about the individual infected. And again, what we're learning, and unfortunately we're having to learn this here within Seattle because of the impact it's had in our long-term care facilities, is that not all of these individuals present with the typical symptoms. And we think that's because they often have waning immunity as you get older, and so you don't have as much of a robust response. Your immune system just doesn't respond as vigorously to the pathogen as you may if you were at a younger age. Not in all patients, but in some. And so this is one of the things that we're identifying, again, unfortunately, because of this experience we're having in our long-term care facilities.
And if the host does respond to coronavirus in such drastically different ways, or can, then what symptoms do they need to be looking for to recommend testing?
I think we're still looking for those same symptoms, predominantly fever, cough, other respiratory symptoms. Occasionally we'll see even nausea or diarrhea, but it's still predominantly fever, respiratory symptoms. But we have to be mindful of individuals. And again, what we've also seen is individuals can be well and then over the day start to develop symptoms. And so again, we're learning as we go forward. We've seen a lot, and we've learned a lot about China's experience and other countries, but we're in particular, because of the patient population that is most affected here thus far in Seattle, we're learning a lot about how this virus behaves in an older population.
There seem to be a lot of concerns now about testing right when we first found out about coronavirus, and some concerns that a lack of readily available testing or willingness to test in the first place may be causing a lot of problems now at the back end. What are your thoughts on this?
Yeah, I think, again, we're actually fortunate that we had the test readily available here, and as I said, ours became available on March 2nd. I think there's always this tension that, it's the same thing if you have a new medication or if you have a new test. It's absolutely appropriate for the FDA and other regulatory bodies to, in a normal situation, we want to make sure that the tests perform well. Are they sensitive enough to detect cases, but also have good characteristics that they're not falsely detecting cases that actually aren't there. Similarly with medications, right? And this is one of the things or vaccines for that matter. We need to ensure that they're safe as well as that they're effective in their activity. The FDA, over that weekend, around March 1st, modified some of their requirements to allow those clinical labs who had developed testing to be able to perform those tests. Initially, when we started to do the test, we had all those positive tests confirmed either in our state lab or within the CDC, and then after a pretty quick period of time, after we had good confidence and validation within our test, that is no longer required. So the good news is that our researchers started from the beginning of January in developing that test, so it was ready to go as soon as we had permission from the FDA. There were some challenges, as people are aware, in terms of initially the tests were only available in the CDC, and there were some challenges when they initially deployed those to the state lab. Those became available on February 28th, I believe, in our state lab here up at Shoreline. So we have the testing capability here, but we still need to use medical judgment in terms of who needs to be tested, at least from the clinical management. Again, there may be a difference from a surveillance standpoint to really see how wide it is in the community, but I do want to emphasize right now, we do have testing capability here. And so again, people who have symptoms that meet requirements and their clinicians have concern, they can get those patients tested, but it has to be based on clinical judgment. And again, the best approach if people have questions is for them to call their provider first and discuss their symptoms that they have with their clinician, and if they feel it's appropriate, then order the test.
Do you have any patients that are expressing concerns that not all providers are on the same page about when they need to be tested? That's some of the concerns coming into our newsroom. It's just,
Yeah.
I don't think that all patients who have coronavirus are always going to have a fever or some symptoms,
Yeah.
And so they're wondering, why is this person getting tested whereas I'm not, even though,
Yeah.
and it seems to be just so on an individual basis with the provider that they just want answers.
Yeah, I think some of the challenge is that this outbreak within our community is changing so rapidly, and new information is so rapidly evolving that recommendations that came out, one day, they may be updated the next. And so I think part of the challenge early on when you see this sort of an outbreak is things are going to change, recommendations are going to change. I think our public health and the Department of Health have done a good job of continuously putting out those updates as soon as they occur. But it may take a little bit of time until we get to that consistency and standardization. I don't think that it's a surprise just because the information is changing so quickly. So I think people are doing their very best in managing those patients who come to them and answer their questions and determine whether or not they need testing, but we're continuing to learn. And so this, I think, we will continue to see increasing cases over the next few weeks. Our goal, and why we've been so hard through our command center, is to really build that foundation. What is that core approach of how we're going to manage these patients and build that infrastructure so that we can handle the increasing volumes that we anticipate over the next few weeks?
I just wanted to add that UW Medicine, as I said before, has been developing and compiling a repository of documents that are policies and clinical protocols that are shared across UW Medicine, but now there is a website for other physicians in the area and actually the country and the world who can sign up for this website, and they would get readily access to these protocols. Where folks can see the rationale for the testing criteria, some of the research aspects, some of the evidence-based recommendations, and some modified protocols, because again, as Dr. Della was just saying, this is not normal care. This is not regular business, right? This is different, and we need to keep a lot of things in mind, like obviously the patient at the center, but also the conservation of the PPE, using our lab capability, and trying to really risk stratify folks and see who is going to benefit the most from this intervention, from this treatment, from this trial. So we're very proud that UW Medicine is really taking the lead in sharing some of these well thought out protocols that are written by UW Medicine experts.
The last thing that I would say on that, though, to be able to effectively manage it, we need the resources. All the healthcare systems need the resources. If we're going to be able to scale our testing needs, so I said we're doing 2,000 now, if we want to be able to scale that to be able to do, say, 10,000 tests a day, it requires resources. And so we've been working hard to be able to get additional funding to be able to support that, because we feel that being able to provide that service to our community is critical, but it does take resources. To be able to set up testing clinics takes resources, right? And so all of our healthcare systems are absolutely doing everything they can to support our community and partnering with public health. But all of these activities and to be able to provide these services, we do need additional resources. And so there's been a lot of discussion, both locally within our government, but also nationally back in DC, in terms of, do we have adequate resources for our healthcare system in order to adequately support our communities as we continue to see this emerging pandemic?
Are these
Another,
two
can we
cases,
just wrap it up, maybe one more question?
really quick, these two cases, are they included in today's DOH numbers, or will they be reflected in tomorrow's numbers?
Any test that comes within the UW medicine that's done through our lab is called presumptive positive, and then it goes to the state for confirmation. So I don't know where we are in terms of the.
Yeah, they actually, and that's how we were doing it initially. And again, things are evolving so
Right.
quickly. So we no longer have to send our positive tests to the
Sorry.
state lab. In fact, the state lab's sending their backlog to us to do testing. So they're positive if they are determined positive within our lab. Whether or not they're in those numbers is just a timing. I don't know the time of when Public Health and Department of Health released their updated numbers.
Right.
So that's the only reason I can't answer that. But the good thing, and again, once we did that initial validation, our test is good to go, and we don't need to do that confirmatory test anymore.
They will report them tomorrow since
Right.
the day after.
And I just wanted to say we learned about this morning, and then we tested everyone at 1 p.m. So we should have data soon.
And what's different is that these patients came in not for COVID, and yet they have it now.
Right.
We don't know. We don't know.
No, the two cases
No, the
do.
two cases have it. Yeah.
Yeah.
We don't know about the rest. We're testing.
Yeah, that's what I meant.
Yeah.
Thank you. Thanks for letting us ask you so many questions.
Thank you.
Thank you, everybody.